Well, hello everybody and welcome to ASDEN TV. So this year we're going to start off ASDEN TV by holding a roundtable to talk about topics of interest, topics that we all as clinicians and as interventional nephrologists are concerned about, and also which furthers the mission of ASDIN, which is promoting excellence in dialysis vascular access care. My name is Catheter. I'm the interventional nephrologist and the chair of the communications committee and ASDEN counselor. And with me is a very, very eclectic and educated bunch who will bring in together their own experiences on topics. Because today we're going to talk about all about catheters. Catheters, catheters, catheters. We love them, we hate them, but we definitely can't live without them. So heading off the roundtable today is going to be Danny Patel, all the way from a passenger lounge in the airport. So I thank you, Danny, for joining us from the passenger lounge. I'm not going to name the airline. So Danny, if you can just give us a little introduction about yourself and just a two-liner introduction, then we'll go to the next person on the panel.
Sure. As some of you may know, I'm an interventional nephrologist practicing in Daytona Beach. I practice private practice interventional nephrology, and kind of in practice for the last 11 years, 100% dialysis access practice.
Excellent, excellent. Aisha, all the way from New York, New York. So Aisha Sheikh, who's a superstar, social media superstar, as I've always mentioned. So Aisha, if you can just give us a brief introduction, although you don't need any.
Thank you. Thank you. It's so lovely to be part of this this crew. And as Karthik said, I'm based in New York City and I'm an associate professor at Memorial Sloan Kettering and Cornell. And my background is in interventional nephrology as well as onconephrology. And I'm absolutely delighted to be part of this group and really looking forward to this discussion today.
And definitely last but not the least, the professor in the bunch, Adrian Sequeira, from all the way from LSU. And so Adrian, if you could give us a little brief introduction of yourself, that'll be wonderful.
Thank you, Karthik. A pleasure to be here with Danny and Aisha. My name is Adrian Sequeira. I graduated from LSU in Shreveport. I'm professor of medicine. I'm also the program director of Interventional Nephrology Fellowship. I've been in practice now for 12 years, and Karthik Ramani used to be my fellow. End of introduction.
Well, I love that introduction, Adrian, and I'm so blessed actually to be joined by such a wonderful, wonderful panel. And in all seriousness, I'm gonna first ask Danny Patel to just talk about, how do we choose a catheter? I mean, how do I choose my catheter? I mean, I had a patient this week who said, Doc, I'm getting some port in my neck. I don't know what that is. It's got 2, it's got 3, it's got something. So how do I choose the catheter? And there's so much out there. Is it like a Toyota? Is it like a Honda? But I want an F-150 because I'm in Michigan. So I'm gonna reach out to Danny. And Danny, if you can lead us off from there, and how do we choose the right catheter? And is there such a thing as a right catheter?
All right, so it's tricky. There's a lot of different varieties. There's a lot of shapes. There's different, sizes and so forth. So it's challenging sometimes to get the right catheter for the right patient. Here are my disclosures. Nothing really relevant to this talk here at hand today. So where do we put the catheter? It's kind of location, location, location. The old saying that they have in real estate. Where are we trying to get the catheter? And I think that dictates a lot of our decision making. For me, 99% of the time, I'm always aiming for deep in the right atrium. Occasionally, you'll have patients though where the anatomy is not suitable for that, and we're actually aiming for the SVC or IVC. And usually, that's kind of we get there when nothing else is working well. For femoral catheters, again, I always try to go as close to the right atrium as possible. I feel like we get better flows there. But the challenge here is that the right atrium, it's a moving target. The cardiac cycle, respiratory cycle, it's always moving. How do we get this catheter in the right place? It's really a best guess, because when they're lying down on the table, you're trying to assume where it's going to be in the long term for when they move and continue with their dialysis. The other fascinating thing is the catheter tips actually move. When you start pumping blood flows 200s to 400s through these tips, they actually vibrate and move. Tom Vesely at ASDAN, I believe, a few years ago, had a model where he showed this, and it's really, really eye-opening how much these tips move, especially with split catheters. What do we do when they're troubleshooting? We try different areas. I use IVUS at times. It helps me to diagnose possibly what the anatomy looks like, if there's any thrombus in the atrium, and it helps to kind of distinguish things when we don't get the full picture through venography. And here's kind of the schematic showing of kind of what we're looking at here. And on the left, you see the velocities and different kind of tortuosities of the movement of blood flow in that right atrium. And again, it speaks to how dynamic this area is. So getting a catheter in the right place is a challenge sometimes. And again, the deeper right atrium is where we seem to have better flows. The key is kind of individualizing. When we pick the catheter size, you want a good variety of shapes and lengths. You know, not everybody on the right side gets the same size. Not everybody on the left side. Everybody comes with different sizes and shapes. It's also challenging sometimes when you're looking at the labeling. Every manufacturer seems to label their catheters differently. Sometimes it's end to tip, sometimes it's hub to tip. And so it's kind of looked at from cuff to tip. And so sometimes it's a challenging, we actually have a little chart we use in our lab to kind of say the most common catheters that come in, if it's this type, maybe this company's catheter is actually a different measurement. So that can be a challenge. In general, in my approach, my tunnel size, I generally do a 23 tip to cuff on the right, 27 on the left, and a 50. But again, a lot of variability. French sizes are also an option with different catheters. For me, I've never really found that they've made that much of a difference. But in theory, you may get better blood flows with a larger French size. It's all very highly variable. But I've never really noticed a significant difference in my patients between the 12 French or 15 French for different patients. So it's not something I get too hung up on with my patients. Different catheter features. Sometimes they're heparin coated, sometimes they're silver coated. In my experience, this adds a lot of expense and cost, especially in a private lab when you're buying all the catheters yourself. I don't really see a lot of benefits. There's not really much data out there that supports this. I suppose if you have patients with recurrent infections, it's reasonable to try one of these things. But they do come at a higher expense, and I'm not sure how much of a further benefit there really is. I've seen patients with florid sepsis with either of these coatings on there, and I don't know if it made much of a difference. Tunneling is variable. I'm old school. I'm used to antegrade. I'm comfortable with that. I think if I was a new trainee or new person coming out, retrograde is a pretty reasonable approach, and it's another choice you have on your tunneling size. Pre-curved and regular standard configurations, I've never found a difference for that. I found that, you know, really that goes back to your technique of putting these in. I don't know how much the curve really helps. If you've got a good banal and exciting, good tunnel place. Stylets. Stylets are another feature that we see on catheters. For me, they're very important. A good volume of my practice is exchanges. And having a stylet in the catheter makes exchanges a lot more helpful, especially when they're, you know, placements for catheters that have fallen out. You're trying to go back in through the site where it fell out, or if patients have had a lot of scar tissue from multiple exchanges. So shape, what kind of shape do you want? I always think about this kind of force, Bubba talking about different kinds of shrimp. There's so many different kinds of different catheter shapes and tips on the market. You just kind of, your head will spin trying to figure out what to do. And so trying to pick which catheter shape is, you know, going through that variety, I want to talk a little bit about how I progressed to where I am. So I started out with a split catheter. It's about 11 years ago. I did this in training. So 11, 12 years ago, we started using split catheters mostly. They have a nice stylet on them, nice for exchanges. The only downside of sometimes is that arterial lumen being a little bit higher up, you know, a lot of the best flow is deep down in the right atrium. That arterial lumen, when catheters would come back and they say, oh, the arterial side's not working, most of the time it's the arterial side. I felt that that was because maybe that tip was a little bit higher up. And so the next generation of catheters that came out, there were step tips. This was a little bit of a progression of the traditional step tip. This is a Duramax catheter. I used this for a little while. They come in a little bit larger French sizes. I found that they didn't work that much better, but they were a little bit of an advancement compared to the traditional split tips. I next kind of progressed to the palindromes, and that was kind of a symmetric tip catheter, which means both tips are deep down in the right atrium. This particular type of catheter comes in different coatings and so forth. I usually use the regular one. And again, it wasn't bad. They did studies on recirculation. That was always the fear of having a symmetric tip catheter that you just recirculate the same blood, but the studies were relatively low. This is kind of the catheter I've kind of fallen back to, the glide path by BD. And BD kind of looked at the palindrome, and if you look at their literature and so forth, they looked at side hole improvements and tapering and so forth. And actually, this is kind of my bread and butter catheter that I use for most of my procedures now. It comes with the stylet. It's good for exchanges. The tips go deep down. And so that's kind of where my default catheter is currently. This is a catheter I use at times, the Centros, and this was designed by Steve Ash. The concept is to have these tips curve inward so you avoid hitting the tips against the wall. And this is a catheter that I use when my traditional glide paths or symmetric tips don't work. I find that in some anatomies this works well. And interestingly, sometimes this works really well higher up in the SVC. When you're just not getting good flows in the right atrium, I'll park this one up a little bit higher up, and these curved tips seem to work a little bit better. I think it works in the SVC because it doesn't hit the tips as much, kind of SVC right atrium junction, but it's good to have this as an option available. This is a new catheter that you're going to probably hear about as they do the marketing more and more. This is the BD Pristine catheter. Dr. Michael Tal kind of developed this catheter. The downside of this catheter is it does not go over a wire. So it's for a fresh insertion. If you're using a peel away sheath or something, you can put it in there, but it doesn't go over a wire. What is remarkable in the small one center study at 60 and 180 days, pretty remarkable, 190% patency rates for this catheter. So I haven't used it yet. I'll probably get it in my hands in the next few weeks and try it out. But something new, this is the newest thing that's kind of on the market that you may hear about. But again, I don't like that I can't use it over a wire. I think that's going to limit a lot of utility for me doing exchanges. And again, this is a slide from Dr. Ross and Dr. Shetta when they were in South Carolina together. And it speaks to the going back to kind of individualizing this, because anatomies are variable. Most of the time, they're going to be what you see as the normal right atrium, but there's a lot of variability in this. This is where sometimes different catheters, different shapes, going outside of the traditional right atrium junction might be the right answer for this type of catheter. So that's pretty much all I have here.
Excellent. Well, thanks, Danny. I mean, that was phenomenal. So I think that, I follow the 3 T's, the tip, the top, and the test. So if I think that, making sure the tip of the catheter is in the right place, the top has a nice smooth curve, and then testing it out. That means if I'm able to get, like a 20 ml in like 3 seconds, then it all almost mimics like 600 ml per minute of flow, and so that's something which I've kind of practiced. I mean, I've always had this fascination of, about why antegrade versus retrograde tunneling, but I've seen that, both work equally, so it's very interesting also about the shape of the atrium. So I've had times when we've done exchanges and used different catheters. So we personalize catheters based on what the atrial type is, just like, you alluded to in terms of Shetta and Dr. Ross at Orangeburg. So I think it's fascinating how the catheter design and type is evolving, but rather than me going on the spiel here, I'm going to ask Aisha and Adrian as well, the other panelists, to give their own thoughts about catheters in general. How do they choose their right catheter? And do they have any anecdotes or stories about where, they've been doing catheter exchanges almost every week? Because I saw a story, and I apologize again. I saw a story on VASA wherein, Dr. Rooney, who's another practitioner with Dr. Ross in Orangeburg, mentioned that this gentleman was pulling out his catheter all the time, so they tunneled it to the back. They placed the catheter in the back. So interesting, very. It's always, as I said, catheters are something which also don't reimburse that well. So in the private world, so it's not something which we go for, but it's a necessity, unfortunately, in this day and age. So Aisha and Adrian, what are your thoughts and comments on how do you choose the right catheter?
So I think Danny's point was, the first slide, location is the key here. And I think guessing size is like the worst thing a clinician can do. If you're an interventionalist, you measure and you place it in the right place by measuring it. It's so many
Correct.
times general nephrologist will call me and say, I think somebody put the wrong catheter size. Look, it's a left-sided catheter and it's this length. And my answer is, where is the tip? Because anatomy can vary, people's size varies, people's position varies when they're on dialysis. Just going after or criticizing someone who placed a catheter based on the catheter size is a little kind of not scientific. So I think the fact that, yes, we all have a ballpark figure, this size for the right IJ, this size for the left IJ, but you have to put it in the right location and you can measure it. And that's part of being an interventionalist. You don't have to guess, you can figure it out. My real question for Danny is, and for the rest of the panel is, how often do you find yourself parking the tip in the IVC? I have done that a few times, especially people who've been catheter dependent for a long time. And, you know, perhaps it's hard to get rid of the fibrin sheath. I'm not sure, even if I'm not able to see the fibrin sheath, sometimes placing the tip into the IVC works. What is your experience been? And this is, of course, not a femoral catheter. I'm talking about a right IJ or even a left IJ. So any thoughts on that? Would love to hear your experience on that.
Yeah, so I mean, I've done it. It doesn't always work great. You know, it's something where it's kind of a last ditch effort. You know, I usually try higher up towards the SVC, and if that doesn't work, then I'll end up kind of nothing else is working. Let me park it down there, and it's usually not great. It's not going to last months and months, but it may last long enough that it's satisfactory to get going. I've started using IVUS a little bit more for these to kind of help diagnose sheaths that we don't see, thrombus we don't see, trying to figure out the anatomy. It's not great, but it's a little bit of a guide to help a little bit, because imaging this area is a challenge as well. You can have the patient hold their breath, but their heart's still beating. And so it can be challenging to get really good quality images in that zone. And a lot of this, unfortunately, is trial and error. You know, you try this catheter, it doesn't work, try that one, it doesn't work. And sometimes you do end up in that IVC. And, you know, is it something you can reasonably maintain long enough? And it's always a challenge. It is difficult. I think there's a lot of undiagnosed thrombus in there. I think that a lot of the time there's thrombus in there that we can't see with venography. But you can see it a little bit with IVUS if you get a proper CT. And there's a lot of clots, there's a lot of, you know, stuff down there we don't want to see. You know, we just want to keep going on and not deal with it. But sometimes that's the problem.
Adrian, what are your thoughts on the fact that, you know, about Aisha, just following on Aisha's comment on, you know, having the catheter and the IVC, and also about, you know, what techniques do you use to accurately measure length and position your exit sites? You know, so how do you use any techniques, or what interventional techniques would you suggest to our listeners out there?
So I use the oldest and the easiest. I just eyeball it. Can you hear me?
Yes, yes.
So our rule of thumb is if you're 6 foot, on the right side, you place a 23 centimeter catheter. And if you are on the left side, you add another 5. So you'll become 27 on the left. Remember, this is tip to cuff. If you're doing tip to hub, you add another 5 centimeters. So that's important to know that catheters are different. When it comes to measurements, they're different. It's from tip to hub or tip to cuff. So that's something to be.
But a lot of that depends on your tunnel length, right? You know,
sure.
So yes. One person's tunnel is twice as long as the next guy.
Absolutely.
So that's the challenge.
So when you do that, you need to know about your tunnel. Your tunnel needs to be long or needs to be short. That's absolutely right. The second thing I noticed in Danny's presentation is he uses a femoral catheter of 50. So I have never found anywhere I've done, you know, my reading on it, I could not ever find what is the right length for the femoral, because it's from you're going in the right or you go from the left. Usually they'll prefer the left because they want to keep the right available if you do a kidney transplant.
That's fine. Yep. And
so I usually found in my experience, anything more than 35 for an average American, you'll be inside the IVC straight away. You don't want to be in the common iliac at all because the flows will be low. Okay. The third or fourth thing I wanted to say was about repeated exchanges. So Danny is right. Okay. We've had cases where we've been exchanging, and we have missed a thrombus. He brought this important point about anatomy of the right atrium. And that's so important, because I tell all my fellows, if you're exchanging catheters, you need to do a dye study to look at the anatomy of the right atrium. If nothing else works, you've changed. You've done everything, you've changed catheters repeatedly, then yeah, you can put it in the IVC. But like I said, there's nothing beats the RA for flow and stuff like that.
Right, I mean, thank you. I mean, excellent points. You know, I'm so sorry. I'm just going to talk a little about the marked, you know, about using of marked wires, you know, and about how we sometimes crimp the wire or the micro wire. So at least, you know, those are some of the techniques you can use, you know, as you measure your exit site. Using retrograde tunneling, you can, you know, be a little more accurate. Some people are very comfortable as well. You know, like if you're experienced practitioners, you just have a sense in terms of eyeballing. During the COVID pandemic, a lot of people were using anatomical landmarks because of the fact that they could not get a fluoro machine in the room. So yes. And with significant accuracy and great outcomes. So, yes. I mean, to endorse, you know, the point of Adrian, Aisha, and Danny is tip-top test is absolutely important. it's very, very important also to understand that eyeballing anatomical landmarks, using crimping, using other interventional techniques, marked wires, adjusting your length, all of this is critical to your outcomes. But once you are sure and have a comfort level, then you can use different indices to achieve your adequate curve and adequate length of the catheter. But I think what is also very important, which is the point which you all brought up, is that there are under-recognized reasons for failure. And those under-recognized reasons for failure, such as thrombi, fibrin sheath, all of that also has to be taken into account. And please consider doing a contrast study. Sorry to interrupt you, Adrian. Please go ahead. You had another point.
One last point I want to do. One of the things that I'm teaching our fellows is to use an echo, because we are progressing with point-of-care ultrasound. So many people in many parts of the world, they don't have fluoro. So they use ultrasound or an echocardiogram to position the right atrial, the catheter in the right atrium. So we are trying to teach our fellows, because one of the things, like Danny mentioned, is an unrecognized thrombus. And that is one of my pet peeves. I'm always looking for that thrombus. So I'm teaching our fellows how to get right atrial views from the echo machine so that we can look for that thrombus.
Great point. So sorry. I was going to say about catheter-related atrial thrombus, cracked. Again, very, very important, under-recognized. Please, please consider, again, to the listeners, please start reviewing those studies on how to evaluate catheter-related atrial thrombus and what are the measures to use. So, yes, over to you, Danny.
No, so Adrian, just a last point on that. Are you treating them? Are you treating asymptomatic ones? What are you doing with these things now?
No, so the way I'm looking for is, if I'm pulling out a catheter, that's when I do it. Just because, I just don't want to miss something. And there is no study right now that tells us how prevalent this condition is. So the guidelines say if it's less than 2 centimeters or 1.5 centimeters, you don't need to do anything. So we are not proactively trying to treat. I only look for it in conditions where I'm repeatedly changing a catheter. In a month, they're coming 4 or 5 times. Well, what are we missing? We're shooting dye, we're still not seeing something. Something is wrong. Right? And so we had a case where we found there was a thrombus sitting there, and all of us have been angioplasting a fibrin sheath, and yet there was a thrombus that was missed. And it was only picked up because we sent for an echocardiogram because we couldn't figure out what was going on.
Excellent. Then what do you do? Do you take the catheter out and treat that patient?
So then the catheter comes out and the patient is on is on Coumadin, and the catheter is placed in another position.
And Adrian, I think your group actually did publish giving TPA to.
Yes.
Yeah.
That was for the TPA was for a clotted axis. We were trying to figure out if we do everything and the declot doesn't work, can we put TPA overnight? That's what we did.
But even in the ASDN meetings last couple of times, there's been presentations with right atrial thrombi causing symptoms, and if thrombolytics didn't work, they actually used a very special machine to extract those thrombi.
The clot retriever. Sure.
Yeah, exactly. So I mean, my whole thing is, if you're going to look for it and you're going to find it, then you feel obligated to do something about it. But it's critical because, as Danny alluded to, it is a very common condition. We just don't know how common it is. And my whole thing is, what do you do when you are about to remove a catheter in someone and you find a clot? And a lot of those otherwise go untreated, and we don't hear about a lot of complications from those. So one wonders, right, when you look for it for an indication, that's a different story. But when you look for it in all comers, it's a different story. What do you do with those tiny clots that, like you said, are probably present in most patients than not?
I think these are great points. I think that, I think this, catheter-related atrial thrombus warrants a separate ASDN TV episode for sure. And especially given the fact that, when do you call the cardiothoracic surge, right? What is the risk of embolization? When do we anticoagulate? When do we remove? Great clinical questions to come, hopefully in episode number 3. No, I'm playing. But the point of this discussion for all our viewers out there was choosing the right catheter is critical. Location. Again, 3 T's: the tip, the top, the test, and please evaluate. And I think to Aisha's point, be specific. Use your tools. Tools to evaluate, whether it's IVIS, whether it's other things. If you have those tools, use it. But please Remember location, location, location. Okay,